Okay, very good.
Great.
Thank you, everybody, for joining. And Jean, and is that Van Han? It's nice to see you both. And I think Cindy Toppin, it's nice to see you too, if you're the Cindy Toppin that Paula and I know. We've been looking forward to this. Like Rich said, Jean and Liz Han have been saying to both Rich and I for several years that we need to know each other, and we have had the opportunity to get to know each other and each other's work this last year. So it's really an honor to be able to tell you a little bit about St. David's Center and how our work in particular interfaces with the issues you are all concerned about as you think about our community's most vulnerable children, those in the child welfare system. That's certainly not all of our work, but we serve a lot of children who are at risk for maltreatment. We serve a lot of children and families who have trauma in their history and are actually have open child protection cases. So excited to have my colleagues share more about the stories with you. And what I'll do is just give you a brief overview on St. David's Center and what our work entails, and pretty quickly hand over to my colleagues so you can hear the stories of our work. And I'm just gonna share my screen here so you have something to look at as I talk. All right, and I'm gonna go like, oh dear, okay, I'm gonna go back 1 second here. There we go. Okay, there we go. St. David's Center, or first of all, I'll just say what are the goals for our presentation and who are my colleagues that will be presenting with me. So I'm Julie Sjordahl, I'm St. David's Center CEO, have been with St. David's for 32 years, I think, if I'm counting right. Started as a home visitor myself and have just had the honor of being on a trajectory here where I've learned alongside some brilliant leaders, been mentored by good people, and have had the opportunity to be part of the development of this good organization. I've been in the CEO role for the last 11 years. My colleagues Lisa Brennom, Paula Frisk, and Kathy Duffy each lead pieces of our work. Lisa leads our center in downtown Minneapolis called the Harmon Center for Child and Family Wellbeing. She'll tell you more about that. Paula Frisk leads our home visiting, our birth to 5 home visiting program, parent-child home visiting all across Hennepin County. And Kathy Duffy is the program director of our foster care program, and we'll tell you not only about how we engage in foster care as a private foster care agency, but also a really exciting initiative we've been part of and had the honor to play a leadership role in called the Quality Parenting Initiative. So our goal today is to provide you an overview of St. David's Center, our services, our approach, a little bit about our results, and then discuss ways that we're providing services and leadership in the child welfare system. Overview. So St. David's Center is a 60-year-old organization. Our name, St. David's, comes from the tiny little church that we started in 60 years ago, St. David's Episcopal Church. And we have been our own nonprofit, non-sectarian, not affiliated with the church for most of our history, but just had this very early start with a church community that had space and wanted to do something good in the world, and launched this treasured organization that was for many, many years a little preschool. And out of that little preschool grew this pretty substantial organization serving children and families all across the metro community. In 2019, we served over 4,200 children and families, and we have many programs and provide it in a lot of different ways. I'll tell you a little bit more about that, but it really falls into these 3 core service areas. We have been and continue to be a leader in inclusive early childhood education, serving about 400 kids and we really only do that work at one location at our site in Minnetonka, though we have a lot of interface with other early childhood centers all over town. the bulk of our work and where we've grown the most over the last 20 years is the second core area. And how we kind of label this set of programs is early intervention and treatment. That in that set of programs, we serve over 3,500. So over 80% of our work is aimed at intervening as early as possible with some of our community's most vulnerable children, kids who have global developmental delays, and kids who have really faced significant trauma in their lives. And then our third core area is home and community support. We serve about 350 families who have kids with special needs, whose special needs are enduring. They're with them for a lifetime and they need long-term developmental partners. So our mission to build relationships that nurture every child and family. And our goal is that we have a healthy and vibrant society, and that children are safe and families are healthy, and that everyone at the end of the day is a contributing member to the success of our community. I'm going to say just a little bit about, so that's the what of our services. I'm going to say a little bit about how we provide our services, and in particular, a little, just give a little bit of a nod to the COVID conditions. So St. David Center, we have two campuses. We have our campus that we've launched from for years in Minnetonka. That's the picture here on the left, with about 60,000 square feet. And it's an early education and intervention center where we provide early education, autism treatment, pediatric therapies, and a range of mental health services. A few years ago, we were selected by Westminster Presbyterian Church to be their on-site nonprofit partner as they built new space in downtown Minneapolis, and that's where we launched the Harmon Center for Child and Family Wellbeing. And it's basically a lot of what we do at Minnetonka in a smaller scale in downtown Minneapolis on a bus line, but also really aimed particularly at the families where trauma is a part of their experience. And so see a lot of families at that location that are struggling because of the trauma in their lives. So during the COVID crisis, certainly we've had to modify our center-based services. We are high touch in-person services, and it took us a while to kind of get back on that, making sure we could do that kind of in-person service in a safe way, but with a strong preparedness plan in place. We're providing modified center-based services at both of the campuses in just very, very modified ways, keeping very strict pods and disinfecting protocols, and minding the MDH and CDC guidelines at every turn. Another way St. David Centers provides our services is through in-home and partner site services. We have a big share of our workforce. We have about 450 staff on our team, and a good share of our team goes out and provides services on location in families' homes and at partner locations. We have a school-based mental health program. We do mental health consultation at child care centers throughout town. We have intensive family mental health where our staff team goes out and works one-on-one in homes with families where providing services in the home is critical for them having access, and then parent-child home visiting. So this range of services at partner sites and in home, and some of that's still being done during COVID. In the last month, we've had to scale that back, but with some safety protocols in place, we've had staff on a very limited basis providing some of that in-home support throughout the COVID crisis. And a new area for us has been telehealth. We launched very early in the COVID crisis in April. We launched a telehealth program. We're kind of set up, had been piloting telehealth, but knew that one way that we could continue to stay tethered to families who had really significant needs would be through really launching and staying close to families through telehealth. And so over 900 of our families have engaged in telehealth services with our staff, 142 staff providing that service, and 16,000 sessions provided over the last several months. What I want to say, just in preparation for my colleagues to tell some stories of our work, is just name that a good section of our work is really aimed at this set of issues, inequities in the social determinants of health. And I know that many of you come to these conversations because you're concerned about these same set of issues. we see family after family that that really struggles with access to health-related services and just access to basic needs. And so on top of that issue, the families that we're seeing have these set of issues at play in the family, and further concern us not only during normal times, concern us even more during COVID. And these statistics should alarm all of us in the community. 1 in 4 children in the United States will witness or experience a traumatic event before they turn 4. 1 in 5 children in the United States has a diagnosable mental health issue. And what I'd add to that is, according to the CDC, only 20% of kids are accessing mental health services that need them. 1 in 6 children has a diagnosable or has diagnosed with 1 or more developmental disability, and 1 in 44 children in Minnesota is on the autism spectrum. So St. David's set of early intervention and treatment services are aimed at addressing these needs and making access as easy as possible for families. So we have pediatric therapies, children and family mental health services. Of our 450 staff, about 150 of our staff are mental health practitioners or professionals. So really giving a lot of energy and attention to addressing the mental health needs across our community. Autism treatment and support, infant and early childhood home visiting, and therapeutic foster care services. And our goal for these services really are 3 primary goals. First, to strengthen the parent-child relationship. This idea that the parent-child relationship is incredibly foundational to healthy development. And so of all the things we do, one of the most important things we do is to pay attention to what strengthening that relationship could look like. Building and improving skills for children that need success across all of their lives, and then partnering with families to mitigate and increase access, mitigate inequities and increase access to quality services, and of course, just support and promote resiliency. This is what it looks like in our set of services. So of those 3,500 clients receiving early intervention and treatment from St. David's Center, there's a range of services, and it's a range of funding as well. So, and if you think of this as a continuum, on the far left, we have a set of preventive and early intervention services, really trying to get upstream when we know a family has risk factors going into the parenting relationship. And Paula will tell you more about what that looks like with the families we see. But we have a set of early intervention and infant and early childhood home visiting programs funded by the county, and really very long-term relationships. We have anywhere from 1 year to 4-year relationships with those young children and their parents to really help them along the path of development, to have corrective experiences and reparative experiences in their parenting, all the way to deep end. So if the continuum, you know, it's that from that early home visiting, which is prevention and intervention, to when a child has a diagnosable mental health need, coming in and receiving one of our therapies. Case management services, intensive family mental health would be an in-home model. To day treatment is a 5-day-a-week therapy for kids who are so struggling and so troubled in their place in development that they need intensive mental health services, all the way to out-of-home placement in a therapeutic foster care program. So to make that really come to life, I think the stories are the most meaningful. And I'm going to do a handoff to Lisa Brennom, who's going to tell you about a client, and in telling you about Alan, also tell you about what the services look like as we meet Alan and meet his needs. So Lisa, you're up.
Hi, everyone. Thanks so much for being here and caring so much about the welfare of kids and families in our community. Like Julie said, my name is Lisa. I'm the Senior Director of Programming at our satellite office in downtown Minneapolis. We provide the same services here, although on a much smaller, more condensed scale. And being in the heart of downtown, our clients come from more diverse neighborhoods, and they can access us a little more easily than Minnetonka through public transportation, sometimes even walking. So I'm going to tell you a story about a little boy who successfully completed our Family Place mental health day treatment program. This program serves kids ages 3 to 7 who have mental health diagnoses. Typically, it's post-traumatic stress disorder, depression, anxiety. Most have a history of trauma in their early lives. They come to programming 3 hours a day, 5 days a week in a therapeutic classroom setting for 12 to 18 months. Our classrooms are small. We have 6 clients and a minimum of 2 to 1 adult to child ratio. And in this setting, our focus is on individual and group goals based on social, emotional, and regulatory learning. So everything we have to have in our systems prior to academics being able to be uploaded and on board. We also require parent involvement. We don't think we can fix kids without parents. We believe in that attachment, and we partner closely with them in providing services in the home, and 2 to 4 times per month, we see them for family psychotherapy or family skills work. So I'll tell you a little about Alan. He came to us through a referral through a county social worker who had just finished the final adoption for him and his 2 younger siblings. The parental rights of both biological parents had been terminated due to a violent relationship between mom and dad and significant abuse and neglect of the kids. Alan was physically abused by his father and often was put in the position of trying to protect his mom and siblings. He was 4 when he came to us. So when he arrived for his assessment, his face looked stricken with fear. This expression didn't change for the entire hour of the assessment. He refused to talk, dumped toys, climbed in shelves, and ran away when the assessment door was opened. Alan was operating out of a place of fear. His base brain, fight or flight. He couldn't distinguish between safe and unsafe places. He was always on alert. He was extremely hypervigilant. He was diagnosed with PTSD and he entered into our program. So the 2 parts of our program, classroom environment and then family. So in the classroom, we provided a safe, consistent, and structured routine. We looked for meaning underneath his behaviors because all of his behaviors made sense. They were adaptive and self-protective when considering all of his history. We didn't let him isolate. We sat quietly with him. We held his hand when he ran away and wondered out loud what scared him and made him run. We didn't get mad at him when he screamed at us. We told him how scared he looked. And when he threw toys, we stopped him and tried to figure out the trigger. Was it the siren that just went by? Did he misinterpret an expression on one of our faces? And we started to give him words for what he might be experiencing inside. We smiled at him every time he arrived, no matter how the day previous had gone. And we were consistent in our message that adults at St. David's were here to keep him safe so that he could feel some freedom in being a child, to play, to run, to make friends. And in the home, we worked with Alan's grandma, who loved Alan and his 2 younger siblings with a fierce kind of love that you could feel in the room. She also predictably felt awful for the kids, which made it incredibly difficult for her to have rules and set limits. She became incredibly distressed when she saw them cry because she knew how much they had already been through. So, for example, at one home visit, in the midst of a conversation, the toddler in the house, Alan's younger brother, was climbing on top of the kitchen table. We were sitting at the kitchen table. He was climbing up on the kitchen table, and then she would hold his hand, and then he would jump off. So while we praised Grandma for helping this toddler be safe in the way he was jumping off the kitchen table, we both agreed it would be hard for her to be near every kitchen table or every school table or any school desk to help him be in control in the community. We worked hard to help Grandma find value in saying no, so the children could feel contained, and so they knew that there was limits and someone was there to uphold them and keep them safe. So at the end of treatment, Alan looked and presented so much differently. Occasionally he smiled and he could be seen running with joy on his face through the playground. He trusted adults to help him. So when he hurt his knee or fell down, he would go to an adult, which wasn't how we experienced him in the beginning. He didn't trust that adults would help him. And he made friends. He became a little bit of a leader as new clients came into the day treatment program. He would tell them the rules, let them know what the schedule was, help them find the gym. He really felt proud and felt smart. So we began to help Alan get ready for kindergarten. And when his home school district heard that he was in a day treatment program, they assigned him to a setting 3 EBD school setting. For those of you who know anything about special ed, there was a high probability that he could be marginalized there, that people would make assumptions about his capacities and have lower expectations than what we thought was fair, considering all of the progress he had made with us. So we advocated hard with Grandma, teaching her how to advocate for herself, and advocated with the school officials as well, and ultimately kind of bargained for a month of a regular kindergarten classroom and a review after the month where they would consider if he could stay. And long story short, he did end up having a very successful kindergarten year. And we felt really proud of him and his family. We continued our work with Grandma and him through some outpatient work, so not as intensive as the day treatment work, to just partner with them as they learn to be in the community in different ways. So I hope this story was helpful in illustrating just kind of one of the ways we're helpful here at the Harmon Center and in Family Place. And I will take questions at the end if anybody has questions about our program and the work we do. And I'll just hand it over to Paula, who is director of our home visiting programs.
Hi, everyone. My name is Paula, and as Lisa and Julie both said, I oversee our home visiting programs as well as our parent-child therapy program. And as Julie talked about kind of the continuum of services that we offer, I feel fortunate that the services that we provide in home visiting range that continuum all the way from prevention and work with prenatal moms through early intervention and treatment in our parent-child therapy program. So we have the opportunity to serve families wherever they come to us and where they're at with their child in the moment that they find us. The story I'm going to share today is about Sam and Riri, and they joined us at a time in their life when they became involved in child protection. Their children were removed from the home and they became involved in our parent-child therapy program. They were receiving in-home therapy twice a week for 2 hours, one time with a therapist getting some specific attachment-based treatment, and the other time with a home visitor who offered lots of additional support to the family and helped them build some confidence and some great parenting skills. We supported both parents at the time, and they had 2 children, a 1 and a 2-year-old, as well as mom was prenatal at the time when we began with them. Mom was pregnant with Sam's child, and Sam was not the parent of the 2 older children, but he was parenting them at the time, so we served them as a family. During our time with them, they had a few bumps in the road. The family became homeless and struggled with many insecurities, economic insecurities. Along their journey with us, they also had some pretty intensive relational challenges, and eventually mom and dad split up. This became one of the biggest challenges that we needed to support them through. Eventually, mom continued to struggle and her rights were terminated. And dad had to make the very difficult decision to maintain his relationship with mom or terminate that relationship and continue working towards repair on the relationship with his new baby. So we supported them through that, and dad and new baby, Riri, transitioned into our early childhood home visiting program, where they received services from our home visitor anywhere from once to twice a week. Eventually, as I said, mom completely lost custody, and so dad continued on. And we did things in our home visiting program. Some of the ways that we interact are providing emotional support. anything that you would typically think about with becoming a new dad for the first time, and all of the emotional challenges that that brings, layered with some the big challenges of being involved in the child protection system and having a huge magnifying glass on everything about you and how you parent. Those big challenges. Our home visitor was able to really think through with him about how the past is impacting his present relationships. He had some trauma in his history that made it really challenging for him to know how to parent and what to pull from. He knew the dad he wanted to be, but hadn't had that experience himself in being parented the way he wanted to parent his little girl. So our home visitor supported him to think through all of those things. She also offered developmental guidance, things like how do you diaper your baby, especially when they're wiggling and trying to move away from you as you're putting that diaper on, to the importance of reading and singing songs. And we have an amazing video of the two of them. I'm sorry, I'm unable to share that today, but of Dad and the home visitor and little Riri singing a song together while Dad brushed her hair. Simple parenting things that we all take for granted that this dad got an opportunity to do, and with the support of our home visitor had a partner in helping him believe in himself enough that he could do them with his little girl. All of these developmental pieces, as well as helping them think through, what do you do with a 1-year-old? What's a 1-year-old's normal bedtime? What do they eat? All of those kind of things, just typical dad things, as well as advocacy. Again, that layer of child protection certainly complicates things, even when parenting is as difficult as it can be. So helping advocate for Dad with child protection to get his needs met, and to help them see the hard work that he was doing to gain custody back of his little girl. We also advocated with other providers. Dad certainly had barriers that were making it hard for him to be the father that he wanted to be. And our home visitors, along with Dad, advocated to get him additional supports in place to alleviate some of those barriers. The work that we really do is around helping parents think about how they want to nurture their child. And this is difficult, especially when the parents themselves, particularly this dad, didn't have a nurturing experience himself. So really learning what nurturing meant and what that looked like with his little girl. We encouraged him to follow her lead and talked about how do you play, again, with little ones and see what they want to do rather than guiding them in the things that you want to do. And the last piece, which I always think is the biggest, is delight. We help them find joy in each other and playing with each other. To watch the two of them together over the last couple of years has been all delight. They truly enjoy each other, and we've seen the transition now from out-of-home placement into trial home visiting. They've been in trial home visiting now for a while, and there are talks that we're very close to having them move to protective custody, which many of you probably know is that last step in a child protection case. And so we're very excited about the progress that they've made and the continued work that our home visitor does with them. And we're excited to be with them throughout this transition as the child remains home with Dad and they continue to grow together in their relationship. And that's Sam and Riri.
Thanks, Paula. Again, we'll take questions at the end, but just want to give you an opportunity to hear from Kathy Duffy, who is our program director of our foster care program. And Kathy's going to tell you more about what we're doing as a broader community, how we're community organizing around some corrective, some ways we're kind of being self-corrective to help our child welfare system come together and set some new goals. And so Kathy's going to tell you about the Quality Parenting Initiative and how that's shaping the child welfare system in some pretty significant ways right now.
Thanks, Julie. Like Julie said, my name is Kathy Duffy. I oversee our foster care programs here at St. David's Center. We have 4 different foster care programs, ranging in intensity from occasional respite foster care up to treatment foster care. And we serve kids throughout the spectrum along that. So yeah, so Quality Parenting Initiative, I'm going to get into exactly what that is in a second, but first I'm going to let you know a little bit about how Quality Parenting Initiative came to Minnesota. So it is a national initiative that came from the Youth Law Center out of California. And here at St. David's Center, we learned about QPI. It was probably about 5 or 6 years ago. We had a former board member who was looking into different initiatives, came across QPI, brought it to our leadership team, and we were hooked right from the beginning. It stood for everything that we believe in as a foster care program and as an agency. So we teamed together. We realized that QPI is typically brought in by states or counties, and here we are, just one private agency, and it was so much bigger than just us. So we teamed together with some other private foster care agencies under Aspire Minnesota to officially bring QPI here. And we launched QPI Minnesota in October 2017. And like I said, Minnesota has been really unique in how we brought QPI to the state. Most sites have it brought in by the government on that level. And for us, it really started with private agencies who work directly with foster parents, and youth. And we brought in the counties and DHS to be part of our discussion on how to help develop solutions to best serve the kids in our foster care system. Along with that, St. David's Center was also able to help secure some pretty significant grant money that's been able to be used to provide stipends for birth parents, youth, foster parents to be able to participate in QPI. So we've been able to send people to the national conference. We've been able to reimburse people for their time and their expertise, as well as we were able to create positions for racial equity leaders in our community to really address the racial inequities that we have in our foster care system. So what is QPI? I could go on for like an hour about what QPI is, but really it's more of an approach to foster care and the child welfare system than an intervention. So QPI really aims to reorient the child welfare system around quality parenting. So it's recognizing that every child deserves a chance to reach their full potential by having strong, positive, lasting relationships and quality parenting. So in order to shift the system toward quality parenting, because for any of you who are involved in the system, that's not always the focus. Quality parenting is not always what's driving decisions. So in order to help shift the system toward that quality parenting, QPI pulls together different stakeholders. So birth parents, foster parents, youth, social workers, guardian ad litems, judges, and pulls everybody together in that conversation to identify what are the sticking points in the system that are preventing children from receiving quality parenting. And if any of you are involved in the child welfare system, I'm guessing you can think of a few sticking points that might come up that really prevent parents from being able to be quality parents, both parents and foster parents. So some of those sticking points could be foster parents not getting adequate training or information about a child before they come into their home, children moving between homes with no thoughtful transition planning, foster parents not being included in the decisions being made about the care of the child in their home, youth in care not having a voice about what their needs are, or foster parents and parents having no connection and therefore not being able to learn from each other what a child needs. So the stakeholders come together. Like I said, I think this is my favorite part about QPI is that it really is listening to everybody's voice, and it's bringing together the voice of everybody who has a stake in the child welfare system, really emphasizing the voices of people with lived experiences. So everybody comes together and identifies what are the priority issues that we want to address right now. And then we have little action work groups, little subgroups that take those priority issues and develop recommendations and develop policy recommendations for ways that we can adapt our work to better serve children and families. So a clear example of that process is the practice of comfort calls. So when kids are placed in a new home, there's often not any contact between the parent and the new caregiver, the foster parent or the relative caregiver, sometimes for days, sometimes for weeks. And we know that parents want to know where their kids are and that their kids are okay. And we know that foster parents can parent better if they can ask the child's parents simple questions about bedtime routines, preferred activities, favorite foods, allergies, really all the questions I would ask another parent if I was caring for their child. So keeping those things in mind, QPI Minnesota has really advocated for the practice of comfort calls, which is a call between a caregiver and the parent as soon as possible when a child goes into a new home, just to be able to share information about that child and check in and let the parent know that the kid is okay. So St. David Center, along with a lot of the other private agencies associated with QPI, we've started this practice a couple years ago, and there was always continued barriers, such as not being provided a parent's contact information or, not having people on board with the idea. But really over time, through continued conversations with stakeholders, we were able to get more and more support from this practice from counties and the state. And through the work and advocacy of QPI Minnesota, we were able to get legislation passed just this past year that now requires that initial call, that comfort call between the child's parent and the child's foster or relative caregiver happens within that first couple of days of a new placement. And that is such a huge win in helping to bridge that gap between foster parents and parents, and to really bridge that relationship, which we know is so beneficial for kids if the parent's child or the child's parent and foster parent have that relationship. So not all QPI strategies involve legislative change. They're not all that big like that. Some are much smaller, such as, through QPI, we developed an information sharing form, a chain of command form, little things that make a big impact. There's definitely some easy wins along the way that don't have to have legislative change. So just want to share a really quick story with you of kind of what those QPI principles look like in practice. So we have a couple of foster parents who had an 8-year-old girl in their home in one of our treatment foster care programs. And mom was working really hard to get her back in the home. She was involved with therapeutic services with our team. So she was doing family therapy, she's doing individual therapy. And mom had some of her own struggles, not much of a support network, unreliable transportation, economic insecurities. And our foster parents really believed that mom could do it if she had additional help. They really felt that that was her biggest barrier, was just not having additional support. So with the support of our agency and the county, foster parents offered their own home for family time between the child and her mom, knowing that that would be the most comfortable for the child, and it wouldn't require mom to have to spend money taking her places in the community. They gave mom rides to and from their house for parenting time as needed. They gave rides to and from appointments as needed. And they always made sure that the child was able to see her mom, and that rides or transportation was never an issue. And they truly were cheerleaders for mom. They also knew that mom was going to continue needing support once the child went home. So the child was able to go home, which is amazing. And they continued to provide that support to mom. They continue to provide formal support through respite through our agency, as well as informal care as needed. And since COVID, they have had this girl in their home multiple days a week, helping her do distance learning so that mom can continue to work and doesn't have to worry about losing her job and losing her home. And it's examples like that of these foster parents. I mean, that's on them, that they are just amazing people who are willing to go that extra mile. But to have the support of the county and to have the support of the agencies working with them to really help remove those barriers for them to be the best possible parents they could be. Because this was not an easy kid to parent, and there was struggles, and I'm very proud of the work that our team did, and I'm very proud of the work that the county did to support them so they could continue to be the best parents possible. So this girl could go home and that she could stay home, which really ultimately is the goal of QPI, is to get kids home.
Thanks, Kathy. So, Stephanie, I don't know if you have the questions organized, or Rich, how you want to go about questions, but we're sure open to conversation or questions as they come up at this point.
All right, so we generally, have time at the end here for Q&A. And we normally keep this to an hour or a few minutes longer, but we'll just keep going as long as people, have questions they'd like to raise or comments they'd like to make. So I just want to say thank you, Julie, and thanks for the rest of you on the team. That was wonderful. And it's just a chance for us to introduce you to how broad and how deep the services at St. David's are. So, so I see one question already from Judy. What was the wait time for a family to receive services? So why don't you start off with that one?
So it all depends. So our range of programs, our range of early intervention and treatment programs each have a different and distinct funding source and different and distinct criteria for entrance into them. So, in foster care, for example, we really try to have enough foster homes that we have immediate places for placement right away. So there is no wait time. Home visiting, Paula, I don't know if you want to speak a little bit to home visiting and what the wait looks like there.
We currently have openings in all of our home visiting programs, as well as our parent-child therapy program too. It does vary, but we are a very large program. We can serve approximately 150 families at any given time. So we typically have some openings. I think the longest wait time we've ever had is 3 months.
Yeah, so it depends on the entry point. So we have a central office of intake and referral where our team of navigators learns about the family and sees what program they might fit into and where we would have openings. And sometimes they might, connect a family to one of Paula's home visitors, and they're also waiting for a spot in Lisa's day treatment program at Harmon Center. So we have, because of the size, the range, and the flexibility of funding, we have some flexibility in how we serve families, which is a gift of that the organization can give to the community.
Well, I have two more questions, and people can just speak up if they have questions as well. But let me give you these two to cover. One is literacy. This is from Mark Newpin. Literacy of parents evaluated or discussed. I believe poor literacy should be an ACE. That's adverse childhood experience. Mm-hmm. And estimate that at least half of your clients, or I guess he means he would guess that half of your clients have very poor literacy skills. So how do you tie literacy? And that's his question.
Paula or Lisa, do you want to speak, or Kathy, any one of the three of you speak to what you see around literacy? It's not something we evaluate as far as I know, but it might be on one of your assessments, Paula or Lisa.
Not something we evaluate as a practice. I would say that we are highly invested in ensuring that our parents and families understand the service. Often things are just read out loud as well. So no, there is no official assessment. There's an investment in being authentic and real and ensuring that our clients understand what they're walking into.
We definitely look at literacy. When we're working with children so very young, a lot of the work that we do is around story time and reading and the importance of that. Some of our parents do have challenges, and so we talk to them about getting additional supports if that's something that they're interested in. But we also talk to them about the different ways you can read books without actually reading the words, and how important that is to just be with your child in the quote unquote reading of the book in different ways and enjoying that with them. It is something we do see in our population, and again, we support how we can. A lot of the families have had educational challenges themselves, and we do run into the issue sometimes when their child is also having some delays, some resistance to getting them some additional support because of bad experiences that they've had in school. And we really lean into our relationship with them and talk to them about what we can do differently so that their child has a different experience than they've had, to get them the supports that perhaps they haven't gotten and didn't get, and providing a different experience for their child.
Okay, thanks. And then Sherry, and I want to say, if you want to jump in and clarify your question or ask a follow-up, please just unmute and do that. And anyone else wants to ask a question. But Sherry has asked in the chat, I think you might have touched on this while I was doing some other work here, finding things, but are your services and supports only available to Hennepin County residents?
No, not only, some of our programs are funded specifically by Hennepin County. So Paula's the program for our set of home visiting services is primarily Hennepin County, or is all in Hennepin County. But a lot of our programs are funded by Medicaid or insurance. So families, if they can get to the Harmon Center for one of the services that we provide at the Harmon Center, we are not limited to Hennepin County. And certainly our foster care program, our host county contract is with Hennepin, but we have multiple relationships with other counties and take referrals from other counties as well. So our primary service area is Hennepin, primarily but because of location, and that's where our host county agreements are, but we're not limited to that.
Great, thanks. Well, other questions or comments from people?
Rich, I have a question.
Go ahead, Phyllis.
Yeah, I guess it goes along with what you've just spoken to. It's kind of a dual question, like how do children actually get into your program, and what are the barriers to children getting into the programs that you have?
Yeah, so we very actively work on networking with our referral sources. So we get referrals from pediatricians, from Children's Hospital, from Hennepin County social workers, from school districts, from Minneapolis, Osseo schools, from Child Protection County social workers. We have a number of referral sources, and we both and we don't just rest on our laurels with them. Our goal is access, and our goal is to make sure that families know about our programs. We do not want to be the best kept secret, and so we very actively network with the places that we believe where children could be falling through the gaps. Child care centers is another place. A child care center, one of the tragedies is the number of children that are kicked out of childcare. And if we can, you think of what that produces, the feeling of failure for kids, childcare center after childcare center failure. And if we can get in with mental health services and behavioral support or a home visiting program before that happens, that would be our goal. So we very actively work in the community to spread the word. But there isn't just one way, any number of ways.
I would say an additional barrier, Phyllis, is some of our parents don't want their 3- and 4-year-old children to have a mental health diagnosis. So 15 years ago, Family Place was a therapeutic preschool and funded in a very different way. And now it's a medical model where children are required to have a diagnosis to get the support they need. So we have had experiences where that's just not where a parent wants to go, to a diagnosis for a 3- or 4-year-old. So that would be the addition I would make to Julie's comments.
So I have a question about the QPI program, Julie and Kathy maybe. And so I'm not quite sure of the scope of it from how you've described it. And is how many, like how much of child protection does it cover, and how many families does it do you work with families, or do you work with the system? And is the goal to be able to work with the whole system in Hennepin County or in additional counties as well?
Kathy, do you want to start?
Sure, that is such a big question, and that's why when I said I could talk about QPI for an hour, I could. So right now we have 12 private agencies who have kind of signed on to QPI, saying like, yes, like we are a QPI agency. We want to live out the QPI values. We want to promote QPI in our work. And we have 6 counties, so 6 local counties in the metro area who have also said that of like, yes, we want to bring the QPI principles to our work. And then we have 3 more counties that we are kind of in talks with. And And this is where it is so different. There are other states where how it was done was like the state of Minnesota said, we are doing QPI, everybody is doing QPI principles, here's what this looks like. Versus in Minnesota, we're starting kind of a little more ground up. So it started small and it's building. The idea would be that every county and every private agency in Minnesota is engaged in QPI in some way, which means that we are all engaged in those principles that QPI holds and working toward changing the system in a way that is better for kids and families. There is also a lot of recognition that what that looks like here in Hennepin County is really different than what that looks like in rural counties. And so the model that we are kind of doing here in Minnesota, that's a little bit different than how the other states have done it, is different counties are kind of launching their own QPI, almost like mini sites. So like Scott County did a QPI launch for their county. Other counties have done their own little mini QPI launches, knowing that QPI is going to look different in each area of the state. And I think that's part of the beauty of QPI is what we do here in Minnesota is completely different than what they do in Florida or Pennsylvania or California. And so it's really tailored to the stakeholders in that specific community. What are the issues you are experiencing? And let's come together in conversation about how can we address those issues. So our issues here in Hennepin County might look really different than what the issues up in Crow Wing County look like. And so we might have really different priorities. We might have really different tasks. We might be doing totally different work, but it's all under that same principle of quality parenting and working to change the system to improve for kids and families.
So in answer to the simplest, that's the best answer. And the simplest answer is yes, it's systems work, Jean. And it's at the foundation. At the foundation of our system currently is safety. And the foundation of a QPI system would be quality parenting. If all you're doing is getting kids from one unsafe situation to safety, and you're not talking about then you build a whole system around only safety. And we don't want children just to be in a bed and be safe. We want them to experience quality parenting because we know parenting is what's going to contribute to healthy development. So whether you're in foster care or birth family, every child has a right to quality parenting, quality, effective, loving parenting. And our system isn't built on that. And so that's what we're trying to change.
So Paula answered one question already through chat, but it was a question of whether a parent can self-refer from Judy Hanks. So you might want to, Paula, say that verbally as well.
I have a question. Paula, you talked about your home visiting program and you mentioned prevention right away. And I was wondering if you could explain a little bit more about how that works.
Well, we try to get in as early as possible before the family has significant challenges in the parenting relationship. So optimally, we would get in with a family prenatally and start talking to the parents about how they want to parent. So in that case, we're on the end of prevention. I think we think broadly around prevention and child welfare is preventing removal of the child from the home. And so in that case, most of our home visiting is done in that way, although we certainly do have cases where the child is removed and we continue to work and support the family to reunify in many cases. Does that help?
Yes, thank you. Prevention is what we all need to be doing in these cases.
For sure.
And I don't know if you heard Paula, it seemed like you might not have heard, but Judy Hank asked a question about self-refer, which you already answered, but not verbally. So you might want to repeat that for everybody.
And Julie, do you want to say more about self-referral? I know many of our families do in our program. Many also get referred by other professionals or other people that they've had contact with. But I guess, Julie, if you want to speak to, I believe the majority of our families come to us through our central office.
Yeah, families can call our central office and just and our navigators will sit on the phone with with a family and just hear their story and talk through the range of services. So we have actually quite a few self-referrals across our range of programs. You know, very few of our programs have only one door you can come through. Foster care would be one, you know, that really is through a child protection referral, but many of our programs have multiple doors to come through, and self-referral is absolutely one of those ways. And we get a lot of families who will call really desperate for some help.
Rich, I have another question. Julie, do you interface with our state legislators at all?
We do, you know, we do on kind of issue by issue and program by program. We're part of a few advocacy groups. Aspire Minnesota is a really strong advocacy group on behalf of child serving organizations. So we interface in that way. We sometimes are interfacing ourselves based on the issue. We've done a lot of work, Kathy and Kate and other members of our private home visit or foster care groups have done a lot of work with state legislators to really help them understand the systems work we need to be changing.
Thank you.
Mm-hmm.
Okay, we have another question in the queue, but I just want to say that we're over our normal time, and I'm happy to stay as long as the St. David's people, feel like they can, and people have questions. But our feelings won't be hurt if you have to move on to some other meeting or whatever. But we had a really good attendance today. I really am happy about that. Thank you all for showing up and participating. And, Mark, if I don't get the question right, just tell us. But Mark Newbin he's a pediatrician and has asked, do county medical assistants, I don't know if you mean workers, if you mean medical professionals, do much screening to look for risk factors and make a preventive referral?
My thinking was when clients apply for medical assistance, insurance,
Mm-hmm.
or other services, does the county administration do any screening to identify at-risk families? For example, I would make literacy skills one of them because I think that is an ACE, and then refer on to programs like yourself. In other words, rather than waiting for disasters, an event, a child abuse event, why not do some screening even in the prenatal?
Yeah, I don't know that is a Medicaid level question when in applications. Paula or Lisa or Kathy, do any of you know? I doubt it is, but
I don't think so. And I guess my caution and worry would be about systemic challenges and a lot of our families' distrust of systems and whether they would even be willing to reveal some of their challenges to those systems or not. We do get a lot of referrals from pediatricians and other medical professionals that they have relationships with, but I'm not aware of any kind of screenings that medical assistance does. Maybe I'm misunderstanding your question.
No, does that make sense that the county you have to do it somewhat discreet, tactfully?
mm-hmm.
One of the things that I would do that I missed when I was in pediatric practice is not recognizing which of my mothers had poor literacy skills. And then I'm dumbfounded that I didn't know this. And when I talk to other pediatricians, almost none of them think about this. I would have had my receptionist nurse kind of tactfully figure out which of my clients were poor readers. Oh, Dr. Nippen wants you to read this card. Well, I didn't have my glasses with me. Check. Then I would know that this is a risk factor for this family.
Mm-hmm.
And when I found out that 70% of prison inmates are mostly illiterate, and I approached some of the police, Anoka Police and Anoka County Police Sheriff, they're quite aware of the poor literacy in their prisoners. Quite aware. That's the only group of professionals I know of. Pediatricians aren't. And so that's why I think even illiteracy would identify a significant risk factor for these families. And I think would give if presented well, will give an opportunity, say, we can help you with your child so that you don't have to suffer the same way that they suffered as children themselves. That's my thinking.
Yeah, it sure makes sense.
If I may comment, I spent 40 years in the child protection system, last 37 at Hennepin County. And Mark, part of what you're raising, I did not work in the economic assistance side of it, so I can't speak definitively about this, but I'm reasonably sure that medical assistance is primarily a financial assistance program, and the eligibility for it is based on income information, not on social need information. So at least on the application portion of it, they would not be looking at factors other than financial eligibility criteria. And I'm going to shift focus for a second on the other part of the prevention program that Judy was asking about, and a kind of a shout out to St. David's. A lot of what I saw over the years is that prevention is largely dependent upon resources, obvious statement. And like back in the mid 1990s, there was a program called Families First, and it was a federal government sponsored program administered through the states, through the counties. And in Hennepin County, it was embedded in our investigations area. And so when we had cases that were coming through investigations that looked like they might need ongoing child protection services, we had contracts with a number of community-based agencies, St. David's being one of them, that we would refer the families to as a prevention to involvement with the child protection system. And the cases would be open for 90 days. And then they were reevaluated from the child protection side of it at the end of those 90 days. That program ran for about 3 years. And then the funding expired. And with the change in presidency, and that's not the only reason in 2000, but funding got cut. And so that program got cut. It was a very effective program, but it went by the wayside simply because of funding. And so like a lot of the prevention programs, to be redundant, it depends on resources. If you have the resources, you can do a lot of prevention work. If you don't have the resources, it's hard to do some of the prevention work because by necessity, a lot of the funding goes to what's considered mandatory services rather than preventative services. Off the soapbox.
Couldn't agree more. So many of our programs, Greg, that used to be preventative programs are now treatment programs because the county needed to be the payer of last resort and said you can get a diagnosis for that kiddo and run it forward. And to Lisa's point, until a child's really symptomatic and you think you can't get a diagnosis, and parents don't want to diagnose a 3 and 4 year old, I mean, that creates this, barrier after barrier. So we really work hard to help families work through that, but that's not prevention, then that's treatment. And then there's already a lot that's happened. And so you're doing repair rather than prevention at that point.
Are there any minority groups, organizations that work with you in the political arena for funding? You do outreach to them?
Yeah, we certainly partner with minority organizations, minority-run organizations. I don't know that we are doing so in advocacy right now, Mark. But
I was just thinking of Greg's. We didn't get the funding.
Yeah.
And it's sort of how much noise can you rattle to get attention, and that's what I was thinking. Can you
great point.
Create a bigger rattle?
Yeah.
Good. Well, let me say last call for questions, and then I think we need to let our hosts get on with they probably have other work. So one last question people want to pop out there?
Quick question for Julie. From a foster care standpoint, how far afield does St. David's range as far as actual home placements? You said you do go out of Hennepin County.
I'm actually going to lob that to Kathy, who oversees all those placements and knows the counties and the home place where our homes are. Can you say a little bit about that, Kathy?
Yeah. So we typically license foster homes, we say about within an hour of our main campus. So I would say we could be a little flexy on that depending on what that family can provide. So like right now, there's just such a high need for families who can take in teens or larger sibling groups. So, if somebody lived an hour away and they could take in teens or larger sibling groups, we would love to license that family for sure. So, but usually within about an hour, because we are doing a lot of face-to-face, well, not currently we're doing virtual visits, but typically we're driving out to the foster homes a few times a month. And so we want to make sure it's, an easy drive for everybody. But then we do accept placements of kids from any county in Minnesota. So primarily the metro counties, but we definitely have kids coming from outstate Minnesota too that are needing some homes.
Thank you.
Okay, well, thank you, Julie and Paula and Lisa and Kate and Kathy for, the amount of time and effort that you put into getting the presentation ready, as well as your time today. This is, it's a great agency. I'm glad folks got to hear more about it. And maybe we'll do a follow-up on QPI. I'll talk to Kathy, to you about who's the best persons to do a webinar on that, because that's kind of gets to the heart of our mission as well.
That sounds great, Rich. Yeah, really our pleasure. Thank you for your time, everybody. Honor to be here today.
Yeah,
Thank
thank
you.
you so much.
Thank you very much.
Thank you.
Thank you.
Okay,
Great
we'll say goodbye.
evening.